Hello and welcome to another questions and answers for families in intensive care and intensive care at home. You can ask me anything today when it comes to your loved one being in intensive care at home, with intensive care at home. And if you have a loved one in intensive care, you can do that and by typing your questions into the chat pad, or by typing your question into the chat pad, or by contacting me live on the stream here, and I will put that link in the chat pad here. Please feel free to text me here. Now, I do these YouTube weekly lives on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 8:30 p.m. Eastern Standard Time. On a Saturday evening in the US, it's 5:30 p.m. 5:30 p.m. Pacific time, and I do them once a week. Now, what makes me qualified to answer questions for families in intensive care and intensive care at home? I am a critical care nurse by background. I have worked in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, where I also worked with intensive care at home for nearly 25 years. I can talk more about that in a minute. We've been consulting and advocating for families in intensive care with Intensive Care Hotline since 2013. We have saved many lives in intensive care with our consulting and advocacy. We have improved the lives for many families in intensive care, and you can verify that on our testimonial section at intensivecarehotline.com. You can also verify that with our interviews, client interviews at intensivecarehotline.com. Furthermore, with intensive care at home, I'm the founder of Intensive Care at Home as well. We have been operating with intensive care at home since 2012 in Australia. Once again, we have helped many families to get their loved ones out of intensive care, improve their lives, and save many lives with our intensive care at home service. Basically, we are sending critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies. Now, we also have a membership for families of critically ill patients in intensive care, where you can ask questions in the membership and you get your questions answered there. We also offer medical record reviews for intensive care patients and for families in intensive care. We also do for our clients in Australia for intensive care at home. We're also providing level 2 and level 3 NDIS support coordination. We're also doing NDIS. We're also doing NDIS nursing assessments, specialist nursing assessments. Now, also want to thank you if you're watching this on replay. Feel free to leave your comments here. I also want you to like my YouTube channel, subscribe to my YouTube channel, click the notification bell for the next video, and share this video with your friends and families. Share it far and wide, and leave your comments below. Now, without further ado, let's read out the first question that's come in during the week from Heather, who says, "Hi Patrick. My dad went from ICU into LTAC and he needed to be put on a ventilator there. He was on it for 3 weeks, then he had the tracheostomy procedure. He has progressed to doing a T-bar, which also means he's been off the ventilator and on a T-bar or a trachea hood or trachea shield or trachea mask for 9 hours per day and the ventilator at night. The day after the operation, his blood pressure The day after the tracheostomy operation, his blood pressure and heart rate shot up. In the evening, the nurses called the doctor and cardiologist, and the blood pressure levels were brought down with medications. Now he's back on low-dose aspirin and blood pressure medication. Blood pressure had not been high since before his hospitalization for suspected COVID in December. He was treated for that only, and we found out later that no wound dressing was changed and wounds were reinfected, causing him to be readmitted to a different hospital 3 days later with septicemia. Now, before I continue reading, I just need to give some context here before I continue reading the email from Heather. And we've worked with Heather very closely. So Heather's dad was in a hospital, and then he went to LTAC, which he should have never gone into LTAC. This is obviously LTACs are specific to the US. They don't exist in other countries or in other English-speaking countries. And he should have never gone into LTAC in the first place. I've made so many videos about that you should never go to LTAC, never, ever. And then he ends up there and he gets on a ventilator. And I am so not surprised, because LTACs do not know what they are doing. They don't have the skills and the expertise to look after long-term intensive care patients. Simple as that. And I verified that just a couple of days ago in a video that I've made, where a Wikipedia page about LTACs pretty much confirms everything that I've been saying for the last 10 years, where families in intensive care should never go to LTAC, and LTACs do not have the skills and expertise to look after long-term intensive care patients. And I'm so not surprised that your dad aspirated in LTAC. That caused him then to have septicemia and then return back to ICU. Then Heather continues. He's had periodic bouts of elevated heart rate up to 165 beats per minute, and they have given him either lorazepam or morphine, depending on whether they think the heart rate is related to pain or anxiety. My father was able to use the Passimure speaking valve yesterday and verbalized that he was in pain and his throat hurts, but he only has had the valve during speech therapy for now. He was supposed to see a foot and ankle surgeon for a consult on Friday for a pressure sore, but they didn't show up. He's being seen by infectious disease and wound care. They have bumped up changing dressings on the right heel on his foot to a daily dressing change. I was able to get some medical records, and I received them only yesterday. And can you review them? Yes, of course we can review them. That is part of what we do. We review medical records here at intensivecarehotline.com all the time. That's part of our service. So if you want a second opinion, or if you want a medical record review after intensive care, that is what we do here at intensivecarehotline.com. But I encourage you strongly to get a medical record review while your loved one is in critical care and not afterwards. I find it always interesting when people call up and they say, oh, I've seen your website, it's really interesting and it's really good information that you put out there, but we think we can do this on our own. And then they realize they can't. And they're scared to spending a little bit of money on us to help them really save their loved ones' lives, or at least improve their loved ones' lives significantly. If you think you can fight this battle alone, you're wrong, because we hear it all the time. Oh, I wish I had found you earlier. I wish, I had gotten your help. The families in intensive care, their biggest challenge is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Now, and in this situation with Heather, she should have never agreed to go into intensive care, to go to LTAC in the first place. The number of families that approach us in the US every week, where they say, hey, can you help us not going to LTAC? Can you help us getting out of LTAC, going back into ICU, is enormous. Now, what Heather isn't saying in the email, but I presume that is the case. When patients go from ICU to LTAC and then they bounce back into ICU, which happens all the time, which is what's happening here with Heather's situation, right? They often bounce back to a different ICU, right? Because the ICU that they were discharged from to begin with no longer has a bed available, because ICU beds are in high demand. So that means your loved one goes from ICU to LTAC to a different ICU. That is madness and is not patient and family friendly. It's not holistic at all. Right? Now, here's the good news. Your dad's got a tracheostomy. He's breathing on the trach collar. He's breathing on the tracheostomy mask. That is a good thing. So now what needs to happen next is he needs to get mobilized. He needs to have physical therapy. He needs to do breathing exercises, and the more time he can spend on the trach collar, the higher chances are the higher chances are you can replace her. The higher chances are, the higher the chances your dad can come off the ventilator, right? So, and that's what needs to happen here. I have not seen patients being weaned off the ventilator if they're not being mobilized. I just haven't. So it's critically important that your dad gets mobilized. That might also help him with the pressure sore on his foot. If he's lying in bed all day, there's a much higher chance he will end up with another pressure sore, So that is a real issue, but it sounds to me like he's on the right track. Now, also, hopefully you have learned from previous experience and not let him go to LTAC again, because they might be trying to push you out to LTAC again. Do not let that happen. Do not let that happen, and don't let them push out again. They can't force you to go into LTAC. They cannot force you. So here's the thing. Once again, I've been talking to families in intensive care since I started intensivecarehotline.com almost every day. I've been talking to families in intensive care for the last 25 years, even when I was working in ICU, So I understand that some of them, or many of you, are intimidated. You need to stop being intimidated by intensive care teams, and you need to push back, right? You have rights. You just need to exercise them. You just need to exercise them, and that's it. Don't be intimidated. Don't be scared, because if you are, they will eat you alive and they will walk all over you. You have rights, just exercise them. I've never seen a family go to LTAC from ICU if you exercise your rights or if you put your foot down. We've also helped many families to go from LTAC back to ICU, right? That is also a possibility. If you are giving in, it's your own fault. I don't want to be harsh here. It's just that families who don't take no for an answer are the ones that are winning. If you will take no for an answer, you won't be winning. If you won't get help from us here at intensivecarehotline.com, we are the experts on patient and family rights in intensive care after all, right? You won't be winning. And if you think you can do that yourself, I can't help you, because 99.9% of families can't really do it themselves, So let's move on to the next question that has come in from Teresa, who says, "Hi Patrick, I'm getting inconsistent messages from ICU staff about my husband's condition. What should I do?" Yeah, it's not uncommon that different people will give you different outlooks, and sometimes the outlooks can be very subjective. They're not necessarily based on facts. They're based on their subjective point of view. They're also often based on people's own experience and experience levels, So, what you need to do is really get objectivity in. And objectivity means that, get a medical record review, get access to the medical records, and also wonder and also start questioning, what is their bias potentially, the ones that are giving you negative outlooks. What is their bias? Is their bias to try and exercise the hospital's agenda, which is often to free up the ICU bed as quickly as possible, right? Or is their opinion biased on real-world experience, right? Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Now, you need to understand one thing, Teresa. 90% of intensive care patients approximately survive, right? That is the first thing you need to know. The ICU team is not telling you that. They're probably painting a very negative picture of your husband's situation, right? And you need objectivity, and you can get that by getting a second opinion, by letting us look at the medical records, and that brings you some objective measures, because we have no agenda here besides helping you and your family. The hospital agenda, like I said, is often to empty ICU beds as quickly as possible, and they can do so by withdrawing treatment, right? So, you have to read between the lines, and you also need to understand that when you have a loved one in intensive care, there are dozens, sometimes hundreds of things happening simultaneously, right? What do I mean by that? It starts from what medications are given, what are blood results, what are x-ray results, what are ultrasound results, what ventilation settings is your husband on if he's on a ventilator, right? And what are arterial blood gases, for example? What do chest x-rays look like? So the devil is in the detail, and unless you can understand the details and piece the puzzle together, you will get confused by inconsistent messaging. I can understand that. For anyone working in intensive care, whether it's doctors, nurses, it takes years of studying and training to become proficient. I've worked in the environment for nearly 25 years, which is why I'm confident to talk publicly about, patients in intensive care. But that takes decades to get on a YouTube video and start talking about it confidently, So I hope that helps you, Teresa, in understanding, how you approach this, how to approach it, so that you can get the best care and treatment for your critically ill loved one, for your husband in this situation. Okay, now, next question is from Ashley. Ashley says, "Hi, Patrick. I'm trying to make the ICU doctors actually listen instead of getting angry with my questions and concerns." Well, that is a concern, that ICU doctors are getting angry with questions and concerns. First question to me here is, what do they have to hide? What do they have to hide? The first thing that comes to mind here, that this is probably not a good ICU, because a good ICU will be open, transparent, and work with you, and will listen to you. So, but what is even more important in a situation like that is, once again, that you get help, that you get professional help, that you have either myself talk to the doctors and nurses directly and ask all the right questions, because I will ask all the questions that you haven't even considered asking when you have a loved one in intensive care. Like I said, intensive care is a very specialist subject. You can't just have anyone talk to doctors and nurses in intensive care without being a subject matter expert, right? And I am a subject matter expert, and I can get all the answers for you, and I can also put pressure on intensive care teams by asking all the right questions. The other thing you need to do in a situation like that is, once again, getting access to the medical records so that we can actually extract the information that you need when you have a loved one critically ill in intensive care. You can't be flying blind. You need a subject matter expert to break down all the nitty-gritty and piece together what is a very complex puzzle when you have a loved one critically ill in intensive care. Now, another tip here is, if you feel like the ICU doctors and nurses are not listening to you and they're getting angry with you, I would escalate this as quickly as possible to hospital executive, right? I would escalate this to hospital executive as quickly as possible, make a formal complaint. Contrary to popular belief, hospital executive complaints work, and hospital executives cannot ignore the complaint of a patient or a family. That is also my experience in 2.5 decades of working in intensive care or consulting families in intensive care, right? So another big challenge for families in intensive care is simply they're intimidated too quickly, right? You can't be intimidated by what is no more than perceived power. It is no more than perceived power. It's just a perception, right? If you give in to that, that is your own fault, and you need to change your perception, right? And you need to change your perception fast. Don't do what 99% of families in intensive care do. They're intimidated. They give in too easily. They don't do their own research. And then they often come to us 12 months, 24 months later saying, oh, my loved one died in intensive care. I'm only finding out about intensive care hotline now. Can you do a medical record review whether there has been medical negligence? My loved one has passed away. You do not want to be in those situations. You should have done the right thing right from the start. And once again, if you think you can fight this battle by yourself, unfortunately, you will be fighting a losing battle, right? You need to get help from day one. Okay. Let's move on to the next question from Mark. Mark says, hi, Patrick. The LTAC wants to send my mother to a low-functioning SNF. She has been off the ventilator for more than 72 hours now. Right. So once again, LTAC in the US, specific to the US. LTAC stands for Long-Term Acute Care Hospital. Now it looks like your mother has been weaned off the ventilator. That's really good. And she's been off the ventilator for 72 hours now, and now they want to send her to a SNF. Now, I presume she also still has a tracheostomy. I would not let your mother go to a SNF unless it's a really good one and unless she has no tracheostomy, right? It is important that your mother no longer has a tracheostomy if she was to go to a SNF. But if she has no longer a ventilator and a tracheostomy, you may even consider taking her home or sending her to rehabilitation, right? So I really think that it's important that you send her to rehabilitation and see, whether she can be rehabilitated there, right? Because that is really important. That yes, you should get her out of LTAC, but not necessarily to a skilled nursing facility. And once again, you are aware that no one can force you to no one can force you for your mother to go to a skilled nursing facility. Right. So now, also have an email here from Steve who says, hi, Patrick. My mother has been in intensive care for a couple of weeks with a pneumonia, and she's on a breathing machine with a breathing tube and a ventilator. And Steve says, the entire ICU team just stopped by and told me that I have two options only. Number one, palliative care and extubation. That means to extubate her, and if by chance she would be able to breathe without the tube, she's fine. If she's not fine, then start a morphine drip and to let her die peacefully. The second option they give me is a tracheostomy. I do not agree with either option. What should I do? Okay. Thank you so much, Steve, for sending that email. So, two things. If your mother has been ventilated for more than 2 weeks, we haven't shared how long she has been ventilated for, a tracheostomy, and she can't be weaned off the ventilator, I should say that. If she can't be weaned off the ventilator, you should consider a tracheostomy. That's assuming you want her to live. That's assuming she wants to live, right? And she wants to be given a chance to wean off the ventilator. Then you should be considering a tracheostomy as an option. If the other thing you should be considering with a tracheostomy is you haven't shared anything about what ventilation settings your mother is on. You haven't shared any of the medications she's on. Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Once again, that is exactly what you are dealing with here, Steve, because you're not asking the right questions yet. So the first question is, have they done everything beyond the shadow of a doubt to try and wean your mother off the breathing tube and the ventilator? I don't have the answer for you because I simply don't have enough information. What medications is she on? Has she been on weaning trials? Has she been mobilized? Has she been having physical therapy? How often does she need to be suctioned, for example? What are arterial blood gases like? What are ventilator settings like? What are chest x-ray looking like? Is her brain intact? Is she obeying commands? Only then can I tell you whether she needs a tracheostomy or not, right? What are they doing and what have they done to get her off that ventilator and extubate her? What steps, what measurable steps have they taken to get her there and avoid the tracheostomy and successfully extubate her? Not sure whether they've done that. And I'm not sure whether you even know what questions to ask to get to that point. Now, the other option you've shared here is palliative care and extubation, and then put her on a morphine drip if she's, to make her quote unquote comfortable and let her die peacefully. Now, I don't know where you stand with this. I believe that if someone is given morphine to help them die, and there are mechanisms to keep them alive, that could be perceived as euthanasia. The definition for euthanasia is to hasten death, right? And once again, hastening death is euthanasia, and that is illegal, right? So it really depends on what you believe in and whether you are potentially wanting your mom euthanized. That sounds horrible in and of itself. I can't make that decision for you. If they did that, they might be engaging in an illegal activity here. You have to think about that. But, and I've been hearing this same question over and over again for many years, that families say, well, they're telling us it's either a tracheostomy or it's end of life. And I go like, no, not necessarily. What about extubation? But again, they're coming to us when they're at the crossroads. That question needs to be asked day one when you are in ICU. Day one, not day 14, right? Once again, if you think you can fly blind and you can manage this situation day one by yourself, unfortunately, you can't. And that's when patients unnecessarily die or don't get best care and treatment. It's a very sad situation, I have another question here from Maria, who says, hi, Patrick. The ICU doctors just stopped by and told me that my mother doesn't need pressure support or continuous CPAP to be trained for extubation. It is enough for her to be under the ventilator and just to do the spontaneous breathing trial tests. And if she passes spontaneous breathing trial tests, she's a good candidate for the extubation. Is this true? No, it's not true. So, when someone is on a ventilator with a breathing tube, right, a spontaneous breathing trial test means they're going from a controlled ventilation mode such as SIMV, ACV, which means the ventilator is giving the patient a set breathing rate per minute. It could be 5, it could be 10, it could be 12, it could be 16, it could be 24, anything, right? Most of the time it's anywhere between 10 and 25, most of the time. So that is a controlled ventilation mode. Some patients can breathe spontaneously on top of the rate that they are given by the ventilator machine, right? So for example, if your loved one is getting 14 breaths a minute delivered guaranteed by the machine, and they want to breathe extra on top of that, they can do that by triggering extra breaths. They can really only do that if they are awake. They won't be able to do that if they are sedated. So in order to wean someone off the ventilator, the next step is to go from a controlled ventilation mode, once again SIMV or ACV, to a CPAP mode, right? And there can be steps in between as well. Once again, let's just say a loved one is getting 14 breaths a minute from the ventilator, and they're breathing 5 breaths on top of that, which gives them 19 breaths a minute. You can reduce, or the intensive care team can reduce the breathing rate maybe down to 10, and see whether then your loved one will take extra spontaneous breaths and triggers more extra spontaneous breaths. If that's the case, and they're not breathing too shallow, oxygen saturation is fine, arterial blood gases are fine, you can reduce the rate further down, maybe to 5, and then your loved one will trigger more breaths and breathes maybe around 20 breaths per minute in total. Then you can switch over to CPAP or to pressure support, which means your loved one needs to take and trigger every single breath themselves, right? So once your loved one is on CPAP or pressure support, that is considered a spontaneous breathing trial if they are on a ventilator with a breathing tube. Once they are on CPAP for many hours, sometimes even a couple of days, once again, they're off sedation, they're awake, they're obeying command, they've got a good cough, they've got a good gag reflex, their oxygen saturation is above 94%, their FiO2, the oxygen that's being given through the ventilator is less than 35%, their tidal volumes are good, their volumes they are breathing are adequate, and adequacy means 7 to 10 mils per breath per kilo. For simplicity, if your loved one is weighing 60 kilos, they should be breathing around 450 to 600 mils per breath. Arterial blood gases must be within normal limits. They must be sitting up, and they need minimal suction. That is when they can be extubated, right? So, but the whole notion that a patient can go from SIMV or a controlled mode such as ACV to extubation, that is not accurate. That is not accurate. I've never seen that. I don't know where this is coming from. And I hope that this answers your question. I've also written an article and made a video about how to wean a critically ill patient off the ventilator and the breathing tube. And I encourage you to type that either into Google or go to our website, intensivecarehotline.com, and type the title into the search box, and you will get the answer there. Again, type in how to wean a critically ill patient off the ventilator and the breathing tube. Okay, let's move on to the next question that has come in from from Naseem, who says, my husband has been in a coma for 6 weeks and he's not waking up. Now, again, this is a very common frustration we are getting. It's very broad. Whilst it is very unique and succinct for you, the question here is, why is he not waking up after 6 weeks? Is he still sedated? Is he still on medication that keeps him sedated? Is he still on medication that keeps him pain-free, such as opiates, such as morphine, fentanyl? Or has he been off the ventilator? Has he been off sedation and opiates for many weeks and he's still not waking up? Does he have a brain injury? Right? So why is your husband not waking up? Does he have a tracheostomy? Right? And if so, if he has a tracheostomy and he's still not waking up, he's off sedation, has a neurologist seen him? Why is he not waking up? There are so many questions here that are yet to be answered, Nassim. I hope that helps you and is a starting point to point you in the right direction. But what we can do in a situation like that is just contact us here at intensivecarehotline.com, and we can look at the medical records, or we can look at the medical records, or we can talk to the doctors and nurses directly and find out exactly what is happening. And if you have any questions here while you're live on the show, just type them into the chat pad or join me live on the StreamYard link here. I'll put the link in there, and then I can answer your question live on the show here. Now, let's get to another question that's come in during the week, and I just need to read it out. Hi, Patrick. My father has a foot wound on his heel that was previously surgically drained, biopsied, and debrided and treated with IV antibiotics. He had a wound vac, and then the wound vac was dry, nothing growing in the cultures taken. He was transferred and finished his course of IV antibiotics for blood infection. When I noticed the foot bandage was not being changed or checked each day and asked the nurse about it, she showed me that her directions were to only change if the bandage appeared dirty or there was a bad smell coming from it. I spoke to the doctors and got assurance that the wound care physician was changing the bandage every 2 days and monitoring it because they didn't want to disturb new skin growth, which makes sense. We were assured that there was no infection, no drainage, and no need for it to be escalated to a surgical consult. Then the wound care doctor met with my elderly mother alone and said the wound doesn't look good and part of it looks soft and they will debride it, but probably can't handle this type of wound and someone else will need to. And then she puts in bracket, the doctor made a chop motion, which probably she's referring to that her dad might need a foot amputation. This was right after a family meeting where they assured us he would have access to a foot ankle surgeon if needed, and that wound care was communicating with the infectious disease doctor. I can't now take my father to see his podiatrist, foot ankle specialist, or surgeon, because after entering this ICU and aspirating and getting a pneumonia, he needed to be put on a ventilator and then finally had a tracheostomy surgery and is in the process of weaning. This is really going well. He's breathing on CPAP for about 7 to 8 hours per day at a very low pressure rate, and respiratory therapy has recommended that he'll be started on a T-bar or trach collar or trach mask, which means he can be taken off the ventilator. I don't want to set back his weaning process, but I can't ignore the possibility of bone infection and it not being monitored and him being taken off antibiotics too early. How should I best ask for both to be addressed, i.e. wound care healing as well as ventilation weaning? So, that is a really good question, Heather. So, Well, the most important thing here is that, how deep is this wound? You have been referring to that he had a back dressing, so the wound must have been fairly deep, right? But what wound care pressure sore is it? Is it a stage 1? Which is that stage 1 is that the skin has not broken through yet. Stage 2 is that they have a break and the top 2 layers of the skin are often red. Stage 3 ulcers or pressure sores affect the top 2 layers of the skin as well as fatty tissue. And stage 4 ulcers are deep wounds that may impact muscle, tendons, ligaments, and bones. So staging really helps determine what treatment is best for your dad. And in a situation like that, once again, you should be sending us pictures and consult with us as part of the membership or as part of the one-on-one consulting. It's essential to, in a situation like that wounds need to be closely monitored daily, especially if they've undergone drainage, biopsy, debridement, and treatment with IV antibiotics to avoid recurring infections and facilitate healing. The approach of changing wound dressings only when they appear dirty or omit a bad smell is not ideal for wound care practice. Regular wound assessments and care from the wound care team are crucial for ensuring your dad's wound heals properly and remains free from infection. The information you receive from the wound care doctor about the need for further debridement and possible amputation and referral to a wound care specialist is indeed concerning, especially following assurances of apparently no infection, no drainage, and no need for a surgical consult. Regarding the weaning process from the ventilator, it's good to hear that your dad is making progress with CPAP and the recommendations to start him on a T-bar, T-piece, or trachea hood or trachea shield. It's also important that they address and manage promptly his foot wound, especially since the wound care physician is suggesting further referral to a specialist. This is essential to prevent serious complications, such as the bone infection you're concerned about, should the wound remain unaddressed and untreated. Have they done any CT scan to determine the extent of the wound? Are they offloading pressure on his foot? Has he been provided with a special type of mattress? Are they mobilizing him and sitting him up on a chair? A prompt evaluation by the wound care team and the infectious disease doctors for possible restarting of antibiotics, along with a consultation from a foot and ankle surgeon, is advised to address his foot wound and determine the next course of intervention for him. Otherwise, it's good to know that you are working towards obtaining the medical records. It's best that we also see and review your dad's medical records fast, because you don't have a lot of time in a situation like that. So that was actually an email from one of our members, because we have a membership for families of critically ill patients in intensive care. And that was actually an email from one of our members. Now, I also have a question here from Eliza. Eliza says, my mother still has a tracheostomy 7 months after a stroke. The ENT did a scope and mentioned she may not be able to be decannulated because her vocal cords can't open enough. Is that true? Well, yes, that may be true. However, there are other questions that need to be asked in a situation like that, Eliza. So, why? Okay, question is, why does your mother have the tracheostomy in the first place? Obviously, you are referring to a stroke. Your mom is 7 months after a stroke. But other questions that need to be asked is, okay, let's just say her vocal cords can't open enough. Doesn't necessarily mean she can't have the tracheostomy removed. She may not be able to talk. But the question is she able to swallow? Has anyone done a swallowing assessment with her, i.e. speech therapy? Has that happened? That's number one. How often does she need suctioning? Right? Can she clear her own secretions? Can she clear her own airway? Right? Okay, yes. I'm not sure what you mean with yes, because I've had a number of questions. Yes, she can. So she can swallow. Okay, all right. How often do they suction her? Also, is this tracheostomy a cuffed tracheostomy or an uncuffed tracheostomy? Do you know? Not a lot of suctioning, okay? Do you know if is this a cuffed or an uncuffed tracheostomy? And also, what size is it? Never been inflated. So it's a cuffed one, but it's never been inflated. Interesting. So that means she must be able to swallow a size 6, okay? All right. So she must be able to swallow if it's never been inflated. It's a size 6, which is reasonably small for an adult size. Does she have an inner cannula? Do you know if she has an inner cannula? It's also sometimes called an inner tube. Yes. Okay. All right. Have they capped the tracheostomy? Have they capped it? Right. So what I mean by that is, have they pretty much sealed it? So your mom is forced to breathe through the nose or through the mouth. Have they done that? You capped her. Okay. How did that go? How long did you cap her for? And what happened when you capped her? For over 48 hours. Okay. All right. How long ago is that? When did you do that? And what happened? Eliza, if you want to, you can also come and join me live here. Might be quicker to get your question answered. You can just use that link that I just posted there. She has a higher respiratory rate up to 35. So that might be concerning. What's her oxygen saturation like when you cap her? The quickest way to get this result is if you join me here live on the stream. If you click on the link and join me live here, that's the quickest way to get this answered for you. 93. Okay. All right. How long ago did you cap her? Is that recently? Last week? Last month? When did you cap her? All right, let's keep it moving. Eliza, when did you cap her? How long ago? Or just join me live on the stream here so we can get this answered as quickly as possible. All right, I'll then move on to the next question. Let me move on to the next question. All right, so apologies, I'll just need to move on to the next question, which comes from Miriam, who says, "Hi Patrick, my family is uneducated and we don't know how to fight for my mother's life in intensive care." Yeah, that is a big challenge. I don't think you are uneducated, because the first step for you is to realize just where your knowledge gaps are, which is something you've identified. There's not everyone knows things about everything. So I don't think you're uneducated. You just don't have the expertise for intensive care. That's okay, but you are educated enough to know where to get help. Right? And that is the first step. Right? So it's very important that you reach out here to intensivecarehotline.com. Just call us. And Eliza is here now. Why can't I admit you? It looks like I can't admit you for whatever reason. So yeah, so that is the first step for you, Miriam, to reach out to us here at intensivecarehotline.com, because you do have what it takes. You just need to engage with the right people. Okay, next question comes from Billy, who says, "Hi Patrick, my wife has been hard to sedate and her vital signs are good, but they are keeping her heavily sedated to keep her calm, and this has been the 4th day on the ventilator. Help." Okay, all right. Question is, why has your wife been hard to sedate? And why are they keeping her heavily sedated? I can only, and it's been 4 days on the ventilator. Now, the sooner your wife can wake up, the better, right? That is for sure. By the same token, it is not clear to me why your wife is on the ventilator, right? So, for example, does she have a pneumonia, and does she need to be in an induced coma to let the pneumonia heal, right? Does she have ARDS, which is lung failure? And again, does she need to be sedated to let the lungs heal? Is she in an induced coma because she had an accident and she had surgery, right? I don't know. Sometimes you do need to keep people in an induced coma for a few days to let them rest and heal. And sometimes it can be difficult to sedate them. Again, it is not clear to me what has happened. And once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what you're dealing with here. Once again, you are dealing with limited information, right? And I can only really help you with as much information as possible, right? But maybe it's not necessary to sedate her, right? More and more ICUs now are moving towards no sedation or minimal sedation if possible, because that helps getting people off the ventilator as quickly as possible, right? So I hope that helps, Billy. Just give us more information here. Give us more information here so that we can help you. All right. We're coming close to the hour mark here. And I need to wrap this up here as quickly as possible. Usually I go for an hour. And usually I go for an hour. Okay. So once again, thank you for joining, and thank you for watching this on replay as well. Once again, we have a membership for families of critically ill patients in intensive care, and you can become a member of the membership if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also get unlimited access and exclusive access to 21 ebooks and 21 videos that I personally have written and recorded, sharing all my decades worth of ICU experience with you so that you make informed decisions, you have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment, right? Also, if you like this video, give it a like, give it a thumbs up, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have. Like I said, I also do a weekly YouTube live here, and you can get notification for the YouTube live if you are a subscriber of my YouTube channel, or if you're a subscriber of our email newsletter at intensivecarehotline.com, or the email newsletter at intensivecarehome.com. Also, I also offer one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I talk to doctors and nurses directly. And I handhold you through this experience, and I make sure you have peace of mind, control, power, and influence. You make informed decisions, making sure your loved one gets best care and treatment. And when I talk to doctors and nurses directly, I ask all the questions that you haven't even considered asking, but must be asked in a situation like that, so that you get the full picture and that you once again make informed decisions, have peace of mind, control, power, and influence. Now, also, we offer medical record reviews, or we do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And I also represent you in family meetings with intensive care teams, and all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. With Intensive Care at Home, we are currently operating all around Australia. We are sending our critical care nurses in people's homes for long-term ventilation and tracheostomy, and we're sending our critical care nurses into the home predominantly for long-term ventilation, tracheostomy, but also for home BiPAP, home CPAP without ventilation, for tracheostomy care without ventilation, home TPN, port management, Hickman's line management, PICC line management, as well as central line management at home. We are currently operating all around Australia. We are NDIS approved, TAC in Victoria, WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, DVA all around the country. We have also received funding through public hospitals, private health funds, as well as departments of health. So please reach out to us. We're also providing level 2 and level 3 NDIS support coordination. And we also provide specialist nursing assessments. Eliza, you're saying, I kept my mother last week. You're unable to join the live link. Yes, I've seen you here, but I couldn't admit you. I don't know why. I cut my mother last week. I have been capping her for some time now. Right. Is your mother at home, or where is your mother? Also, if you are an intensive care consultant watching this, we want to hear from you, because we are currently expanding our medical team for intensive care at home. And if you have bed blocks in your ICU, we also want to hear from you, because we can help you getting your long-term patients home much quicker, and you won't even pay for it. Now, thank you so much for watching. Eliza, sorry that I couldn't answer your question and I couldn't get you on the call here. You can come back next week, same time next week, or you can reach out to us at intensivecarehotline.com during the week, and hopefully we can help you there. Thank you so much for watching, everyone. Give the video a like, subscribe to my YouTube channel. Have a wonderful day. Take care for now.